Good morning, the dignitaries on the dais and the people around to listen to us. So I'm Dr. Manisha Sahu. My topic is implementation of antimicrobial infection control and diagnostic stewardship in a tertiary care cancer center. So basically we wanted to implement it. Ours was a new setup, just 4-year old. And from the beginning we had planned this implementation. What we did, our objective was to reduce the unnecessary use of antibiotics, reduce the hospital-acquired infection rates, and prevent any MDRO-related outbreaks in our hospital. So basically, it is antimicrobial stewardship, that is right drug, right dose, right doses, right time, and right diagnosis and infection control measures all together clubbed so that we reach our objective. So first pre-implementation phase, we did survey, antibiotic prescription audit, then we jotted down all the policies and procedures, SOPs. Then the implementation phase, where as a part of antimicrobial stewardship team, we used to do daily rounds and MDRO surveillances as well simultaneously, and daily MDRO list circulation, and accordingly transmission-based precaution was taken. And post-implementation, we did audit of the prescription and necessary feedbacks wherever necessary. So this is our successes made so far. When we began with the culture rates were only 36% in case of empiric therapy, which was improved to 75% before initiation of antibiotics, unless the patient is very severe. Then double anaerobic coverage was almost 80%, even they used to give meropenem along with metronidazole, which has reduced to 3%. The average cost of surgical prophylaxis has reduced from somewhere around 1800 to somewhere around 250. And there was no mention of review dates in the drug chart, and initially it was just 11%. Post-implementation, it was somewhere around 87%. And the adherence to surgical prophylaxis is around 95%. We also calculate the use of high-end antibiotics like ticoplanin, meropenem, colistin, etc. And the DDD, that is daily defined doses, and the duration of therapies have been very minimal as compared to many other studies that we have come across. And all the high-end antibiotics at this point of time are guided by the culture reports. I mean, even if it is started initially, it is being reviewed at 48 to 72 hours with a culture report. We also looked into the HAI rates. So SSI rate, which was initially started at somewhere around 24 per 100 case surgeries, and our cases are mostly head and neck oncosurgeries, and now it has reduced to somewhere around 4 to 5. The CLAPSI rate due to PICC, our patients need chemotherapy, they are on PICC lines or chemoports, and the rate of CLAPSI was 12.5%. We did some clinical audits and necessary steps were taken, and now it is around 0. For last 3 months or so, we don't have any CLAPSI due to PICC lines. Overall bundle compliance for the care bundles was 90% post-implementation. And most of the PICC lines were initially having antibiotic prophylaxis with ticoplanin, which was not necessary. After thorough discussion with the clinicians and with data, now no ticoplanin is given as a prophylaxis for chemoport or ticoplanin. We have changed the dressing protocols, as well as hub cleaning is a mandatory thing. We do regular audits about the care bundle. So far in last 4 years, we have not got a single outbreak of any MDRO infection, barring for a few occasions where we got a Candida auris infection, but within time, because of the high alert system, within time we reduced it to, we curtailed it with just 3 cases in private ward and 3 cases in the general ward. The major hurdle during this was convention. Like we give like this, so that mindset has to be changed with persistence from the clinical microbiology person and the regular interaction with the clinicians. So a structured and integrated multidisciplinary approach of AID model is definitely a way forward to curtail the antibiotic uses and reduce the HAIs and MDRO rates. Thank you.
Thank you, Doctor. Now, open to questions from the jury.